Welcome to a special edition of At the Table with CAHSAH. We're going to do something a little bit different this time, actually different over the next several weeks, 8 weeks to be precise. So in addition to our regular podcast, we're going to do a special series that takes an in-depth look at California's new Hospice Emergency Regulations. Not just hospice regulations, emergency regulations. And for my money, I would guess it's probably one of the most significant regulatory changes our industry has faced in years. Now, each episode in this series is designed to help hospice leaders understand not only what the new regulations require, but why they matter and how they may impact your organization, your staff, and ultimately the patients and the families that you serve. But the conversations are only the beginning. Each of these podcasts will be followed by a live CAHSAH educational webinar the week afterward. And in that webinar, our panel of experts will go beyond the discussion and way into practical implementation. So at the end of the day, the webinars are going to provide a much deeper educational dive into each topic, along with an opportunity to ask questions of the experts. So if our conversation today raises any questions for you, good. We hope that it does. And we invite you to register for the webinar at the CAHSAH website. That's CAHSAH.org. All right. That being said, joining me through this special series are three of California's most respected hospice experts, and they truly are very knowledgeable, brilliant people. Sharon Fredericks is a nationally recognized hospice consultant, and I found out at dinner at CAHSAH a week or so ago, she loves rock and roll, but she's got decades of executive leadership experience, helping providers navigate regulatory compliance, quality improvement, and operational excellence. Cindy Hatton has spent her career helping hospice organizations strengthen clinical ops, documentation, survey preparedness, and leadership development. Her practical approach has made her a trusted advisor to providers across California. And finally, Eric Peterson brings extensive experience in hospice operations, regulatory compliance, and organizational leadership, working alongside providers to successfully navigate an increasingly complex healthcare environment. Together, they bring decades of real-world experience and a very deep understanding of both the regulations themselves and the operational realities that all of you as providers are facing every single day. My name is Mark Wilson, and this is our Hospice Emergency Regulations special series from At the Table with CAHSAH. So first of all, thank you all for carving out the time, all of you. Hello.
Hey, thank you, Mark.
Thanks, Mark.
I wonder if I could start with Cindy. Could you just kind of break down for us what this whole thing is about, the California Hospice Emergency Regulations, and why it's important?
Well, we've known for a long time that there has been certain pockets of fraud in California in our hospice programs. And in 2020, the state of California conducted an audit, and they found a series of concerning things. They found agencies that had administrators that were overseeing up to 27 agencies at a time, people on their personnel records that weren't even there, hiring people with no experience in hospice at all, and many other things. But those are the ones that really focus on the topic we're going to talk about today. Having leadership that's not qualified or overstretched and unable to oversee impacts the quality of care that these agencies provide.
I have just a couple of questions for all of you, but Cindy, I have a follow-up on that. You mentioned fraud prevention. Is it really about fraud prevention, improving quality, or maybe both?
I think it's both. I think the fraud prevention, it really hits more on the billing and the payment side, but it does impact patient care and quality patient care.
Okay. I want to go to Sharon next and ask you, because this is the first thing that comes into my mind, having been in home health and hospice for a couple of decades. Are these regulations going to increase operating costs in any way?
If you were running an agency that was following the existing regulations, it will add some, yes. There's ratio of nurses, so you'll probably have to have a few more RNs. And there's going to be much more oversight from CMS that your data is okay, perfect going in. You should have a compliance program, which I know Eric's going to talk about at some point. It There will be so much oversight that I expect that the quality department and the compliance department, along with leadership, is going to have to put out education hours, or the clinicians in the field are not going to understand what's happening around them.
And as a result, do you see that there will probably be ultimately improved patient outcomes and patient care?
Most regulations are written to support something in the public, whether they're agricultural, healthcare, anything, but people don't always follow the intent of the regulations. And I think that's some of our concerns now, is that there's so many of the new regulations, so much that the agencies are going to have to do. But yes, overall, it should improve the quality of care. And to back up one of the things that Cindy was saying about, and you said, will there be preventative measures in this? Some of the fraud and abuse was also the eligibility, that those patients didn't need hospice, they stayed on hospice too long, or they didn't even exist and they were passed from agency to agency. So that type of quality of care will go out the window. CMS is definitely on the eligibility track.
You know, I've often wondered, because I've met such wonderful people. It's hard to believe that there are people in the hospice business that would want to defraud the government and the citizens of the United States. And yet we know that they exist. But do you think in some cases it's not people who are willfully wanting to commit fraud, but they're committing errors and they don't know it?
There's a combination of both occurring, Mark. I mean, truthfully, if you look at some of the, the more fraudsters out there, for lack of a better term, bad actors, multiple hospices, out of the same address. I mean, that's just
Well,
an
that's willful
impossible,
fraud. Right.
right? That's
Yeah.
pretty much straightforward fraud. It's like, especially if it's not being, filled with personnel. So that's actually one of the new, office space requirements that California has put out there, which I think, for those of us doing the things right in our industry, there's going to be some benefits to these regulatory changes, certainly.
One more for you, and then we can drill down a little bit on what we're going to experience in the webinar next week. Um, what do you think providers should understand about we'll call it the purpose or the philosophy behind these regulations before they just start checking off compliance boxes?
There's a variety of to-dos that each organization is going to have to prioritize, and they're going to be slightly different for each organization. But for me and what I'm looking at, there's I think kind of the ethical pieces behind the regulations is the nursing ratio, and being able to kind of prioritize ultimately what we're all here for, which is to deliver high quality care. Geographical service area is another topic that we're going to be covering. The nursing patient acuity system, I think those are kind of the three that really stand out to me. Besides the training for your management personnel, not just their qualifications, but ultimately how you have to invest in them at new hire, and also how you have to invest in them on an annual basis to ensure that leaders aren't just being brought up the food chain because they used to be good in the field and now all of a sudden you're in the office and there's like, hey, the Wild West, figure it out on your own.
Right.
California has provided a structure which to me, I think is going to empower and improve the organizations and the industry as a whole, because sometimes we're wrought with you're good here, so eventually you'll be good here, and that just doesn't come to fruition all the time, especially if you don't give them the fundamental pieces, which
Yeah.
are the rules. I was told early on in my career, you can love the organization, but you're better off loving the policies, and it took me about a decade to kind of figure out that actually made sense. The first time I heard it, I was like, that seems strange.
So much.
But it's the truth, and here we are being sort of spoon-fed, more or less exactly what needs to occur, and I think with good intent from California. But it's certainly the most prescriptive, and I think the biggest change I've ever seen in my career in this industry, and probably outside of creating the hospice benefit as a whole, which, was a great thing. This is one of the biggest changes since that time frame.
And it feels like it's just the beginning for some reason. It's like, this is just the beginning of that increased oversight and scrutiny. And that's not necessarily a bad thing, correct?
No. And I would say that, there were many agencies who had not been surveyed. I mean, on-site surveying is very important. You
Hmm.
cannot just look at paper and say and know that what's happening. So you've got to go on site. So that's also included in the regulations as well. People have got, we need to have people on site, going out on visits, checking offices, all those things.
So I just have one other question before I ask you to sort of delve into the menu for the, not the podcast, it's the webinar. Thank you. I often, there's so many great providers out there, and you don't
Hmm.
have to be, and correct me if I'm wrong, you don't have to be a large organization in order to be a great hospice. And I think sometimes, we don't see that. I wonder if the smaller providers are at a disadvantage with all of the extra oversight now. Can you speak to that? Any three of you?
Would say, I always think about that when I look at those rules and regulations. I always think about the small organization. We had a member who was in Bishop, California, and I always used her in my mind whenever we were talking to legislators or looking at legislation, because it was a very small organization. It was the administrator, the director of patient care services. That was it, and then the staff in the field. So you've got all these regulations. Bigger organizations, they have a whole quality department who can audit charts. They've got your compliance officer. They've got a robust compliance plan, all these things. Well, you're talking about two people who have to divide and conquer
Everything.
all of these things. And so, yes, it does impact them. And that's why for us, we want to give our members very simple ways of implementing, not some big complicated thing, something very easy for them to implement, because it might be just two people who are doing all of this.
Right. And that's what we're going to get out of the webinar, I'm assuming, but you're going to tell us right now. The things I take away from the webinar next week are things that I can implement right away.
And to add to Cindy's point, I mean, even if you are part of a larger organization, I mean, to stay on top of all of the different, accrediting bodies or overseeing bodies, to stay up with the rules, so to speak, between changes at the county level, the state level, the federal level, the OIG putting out other, sort of like talking points or action items. It's hard, and I just would encourage everyone listening to participate and be, a member of the association. Certainly, stay on top of the newsletters and all of the different publications that come out there from all the associations within our industry, because they have teams of people helping you to know that, hey, at least something's coming down the pipe, or better yet, here's an implementation strategy that will be quick and easy for you to understand. Uh,
Exactly.
and the OIG, while they might be a little negative at times, we all I think, feel, right? They do some good stuff. And I heard this, you're talking small mom and pops. One thing that just came out that I was kind of excited to hear is that, typically when you're getting a referral from a hospital system, they want to communicate that electronically. Well, the vendors will charge you a fee to have access to that electronic communication. The OIG just put out a stipulation that no longer allows them to charge you that money. So for the mom and pops, that actually is a humongous advantage, because now the Rolodex of their patient census coming out, right? It's going to be fair, equitable, and transparent. And now everyone has the same opportunity to say yes at the rate of speed that these referral sources want. So it's not all negative, but
That,
to
that
stop all that.
that's great to know, Eric. That's
Yeah.
tremendous. Okay.
Yeah.
No,
So
it's not all negative. I just think there's such a volume to try to comprehend and disperse through anywhere from 2 to 20 people, even if we divide up chapters. It feels like it's overwhelming, but if you do pick it apart piece by piece, it does fall together.
So that's what you all are going to do in your webinars. You're going to make it very easy for people like myself
We
to be
hope
able
so.
to understand it. And we're starting with hospice management qualifications. And I've heard a few things that have changed. And then we're going to geographic service area and then nurse ratio and patient acuity system, et cetera, et cetera, et cetera, et cetera, week by week by week. And so, could you just sort of lay out for us what the takeaways are going to be from this first webinar on hospice management qualifications, and maybe give us a little taste of what some of the changes entail, and more than that, how it's going to affect some of our providers?
Well,
I
I
do
think
think, Cindy, I'll let you do that, but I do think Sua, our CAHSAH president, has put together some really good paragraphs of what we're going to be talking about too. And that's how she'll introduce some of the sessions that we're talking through.
Hmm.
But so there will be that to also guide people of who should listen in weekly. And um, they are talking about making it an audio so that they could purchase that series later if they wanted to get that one session in. But
Yeah.
Cindy, go ahead, because I know you're the first
I
speaker
know,
next week.
I know the CAHSAH is trying to, and this that's one of the reasons we're doing this podcast, is to be able to engage with the membership in a lot more in different ways and allow them to hear what's going on in real time, as opposed to maybe waiting for a month to get the next newsletter
Yeah.
or whatever. So yeah. So anyway, yeah, Cindy or
all right.
Eric.
So the first one is, they identified hospice management team as the administrator, director of patient care services, and the medical director. So they concentrated educational requirements and also qualifications. Our previous Title 22, which was the standards of hospice quality, had a very, very vague um, description of what requirements are as far as is qualifications. So this is very prescriptive. It identifies degrees, bachelor's degrees for nurse, for administrator, and for the bachelor's degrees. And then, of course, a physician is licensed in the state and it's valid. Those are the two for the physician. The one area that I think is a concern that we are going to address is how do you know whether your person, what should you be doing? Um, the main thing for our take is that you've got to review resumes, and I'm going to let Sharon talk a little bit about how she does that. Um, and then we are working with the state right now to tell us exactly what we need to do. If your administrator does not have a bachelor's degree in a health related field, we know that many of our members have bachelor's degrees that are in business and other different aspects of business, and we need to know what we're going to do about that, because these are some people who've been they've been administrators for a long time. Their agencies have good records. They've had clean surveys, and so but for some reason they did not add a experience requirement. The director has that, the administrator does not. So we are clarifying with CDPH this week of how are we going to make this transition.
Yeah, and it's a big divergence from the federal regulations, especially with the absence of that sort of grandfathering in approach for experience. So yeah, a lot of hospices, run the risk of being cited, with not providing the right qualifications at the leadership level, which can be a really significant finding in any survey. So, number one, be informed of what the rules are, and number two, we'll walk you through ultimately the steps of how to improve the review of the resume to make sure you're capturing all the supervisory requirements right, and understanding if there are questions as to whether or not those hours qualify.
Hmm.
That's exactly what we need, the membership to bring to us as an association and as individuals who will be participating in these interactive webinars. So we want to be able to get you exactly what you need, and the specifics will matter.
It also has to be your alternates for the administrator and the DPCS have to have qualifications, and that really was not always looked at that seriously before. If they could need to step in for a vacation or a short leave of absence, as long as they knew the priorities of how to operate
Yep.
and be involved in operations, but now they have to have the same qualifications. And that will be probably some staffing changes, expenses,
Yep.
lots of education. And what
I
I
think that's a great
usually
point,
find in
Karen.
resumes is especially nurses have the experience, the supervisory background, and they don't think of their activities that they do as supervisory. And usually they have enough information, they just haven't written it down. So interviews, if the resumes don't look good, start talking to somebody and, saying this is what I've done in my career and fill in those blanks, and you'll probably be much more qualified than you realize.
Yeah, and I just want to add on to that statement. I think it's a great point you made, Sharon. I mean, the designee or the backups, as they've been kind of referred to historically, I mean, organizations had a variety of ways of identifying those, which could be like written on a cocktail napkin, here's my designee, nowadays it's got to be on the license, on the application, right? So, and then all of the work that goes into training those individuals,
Hmm.
both at new hire or annually, is important. And there's caveats as to how do you define a new hire, right, with or without experience. So those are the types of things that Cindy and the team will be talking about as we dive into the deeper details.
Question: was this stuff coming down the pike anyway, or was it sped up just because of the fraud and abuse issue that finally was they pulled the covers on?
Say 2022 was the trigger point when the audit came out. And that's exactly because they found agencies where an administrator had 27 agencies they were overseeing. So, those are the kinds of things that sort of set this in motion.
Yeah. And now you have to show reasonable evidence of an actively engaged administrator,
Mm.
not just someone who meets the
Not somebody that
qualifications on
lives in
paper.
another state.
Right,
Yeah.
right.
Yeah.
And these are
So
all new things. These are all new. This is all part of the new structure, the new
Yeah.
emergency
Yes.
correct. Yeah.
regulation.
And as you said, Mark, it will bring better quality care in the long run to the patients
Yeah, I mean,
and to the clinicians because they're going to know the leadership a lot better.
if it does that, who could argue it? I mean,
Right.
I haven't heard anything. Of course, we're only one subject in here, but I haven't heard anything that I'd be like, well, that's ridiculous. I mean, it all sounds fine. I was just kind of curious about whether they were things that were they were planning, for years, or whether they kind of got together and went, oh boy, we're in trouble here in California. We better do something to show people we're on the ball, and we're
Right.
making changes, and we're
Right.
requiring people to do what they need to do. And I'm guessing there was a little bit of that too.
Well, and I think too that they've defined also for medical directors who are who work concurrently employed. There's regulations around that. Um, so yeah, and then the other thing we're going to cover in there is the people and then their designee. What is the documentation that you need to keep to make sure that you've got it? So when the surveyor walks in, you've got that information, and it's all in one place, and it makes sense, and all those things. So we'll go over all that with them as well.
Okay, what else? We got another minute here, and then I'm going to wrap it up. What else can you
I
tell us
think it's
about the webinar?
important to know, Mark, that especially like Cindy says that they're looking at everything, is that there's ways to be involved. There's the hospice committee, if you're a member, that you can certainly join in CAHSAH. But Tanya is making questions after questions, a lot of them fed by us three and other members writing in, going, what about the flex programs? What does this exactly mean? How can we get this done? And so Tanya's been on the forefront of connecting with CDPH, and we have 2 more meetings lined up with them. We hope for some answers or clarifications. CAHSAH, the CDPH at the CAHSAH conference was there, and you can tell they're looking at these. but they may not. Well, what did you say earlier, Eric? They're the regulators, but they're
Well,
not the teachers.
they're definitely not the teachers here, and they sometimes write rules that they don't really fully understand the implications, right, themselves. And so what's great to me is being part of the association and being part of the committees and then participating at the conferences because, what was it, like 4 days after we did our pre-conference, probably literally the day after the CAHSAH conference ended, the CDPH put out an AFL 2620 for those of you who want to read it, right? In response to all of the inquiries, all the questions, all the concerns that ultimately our industry has, and CAHSAH was able to help represent. So there's stuff that you can find out that are never written down in any legislative body or any regulatory, chapter. And so being an active member and involved in your industry, right, is something that it just is becoming more and more important, and ultimately is the way that you can be sort of at the forefront of what are these changes and helping to enact them, helping to hopefully re-guide them in the right direction. So all the advocacy and the time that's spent, from Cindy's behalf and Sharon's, to basically support our industry is just crucial, and we all will benefit is so long as we play a larger role, and we are already with the role that they're playing. So I'm very grateful for this opportunity to share our information with the group.
Okay. And it's going to be stellar. I know it is. I can't wait to see it. I have one last question for all of you. Pop question. What's one thing every hospice CEO should be doing this week? Sharon, go.
Pray.
I won't say what I was thinking.
Don't get
Listen to the
sick.
podcast.
And
Listen to the podcast.
sit down and read it, because when I read the regulations and then
Yeah.
you read what the feds just did with CMS and another raid, our regulations would keep you hopefully out of the picture of the CMS raids.
Yeah, I think California's got this stringent regulatory guidebook, so to
Well,
speak.
we're setting the precedent for the nation.
We are.
Absolutely. Yeah.
Nurse ratio is nowhere else. There is no other requirement. So I think that I'm like Sharon. If I was the CEO, I'd print that stuff out or pull it up if you'd like to read on your computer. Read the 90-something page regulations, and then I'd be pulling resumes and looking at the
Yeah.
resumes of
It-
the administrator, the designee, the DPS and designee, and the medical director and designee.
Yeah. I would just point out in the regulations for Title 22, there's a couple, I think, distinct definitions that are important for everyone, especially the larger, businesses to understand, and that is your parent office, definition of rural area, multiple locations, geographical service area. There's going to be, I think, some challenges that the smaller companies are going to face, but as well some of the larger companies. And in the end, as an industry and as a whole, if you're doing it the right way, and you're following the flexes and all the other opportunities, right, to appeal and to seek clarification, we will all come out of this on the other side, clean as a whistle. And it will help our industry long term because of some of the fraud and abuse that will be rooted out. So,
And we
Sorry.
will build some better leaders.
Yes,
absolutely.
and leaders for the future with the designees.
As we've discussed today, understanding the regulations is really just the first part. Successfully implementing them is where the real work, I would guess, begins. And that's exactly why CAHSAH has paired each episode in this special series with a live educational webinar the following week. Again, during the webinar, Sharon and Cindy and Eric and others, all experts, will take a much deeper look than we did today. We didn't have enough time today, of course, but they'll be taking a much deeper look at today's topic, discuss practical implementation strategies, share real-world examples, and best of all, answer your questions live. So if today's conversation was helpful, we encourage you to continue learning with us. Visit the CAHSAH website to register for the upcoming webinar and reserve your place. And I don't care who you are, administrator, director of patient care services, medical director, business development person, These sessions are designed to give you practical tools, and I think we can tell just by what Cindy and Sharon and Eric talked about, they're going to be able to do that. It's things, and their goal, as they just said, is to give you some things that you can implement right now, today. So thank you for joining us for this special edition of At the Table with CAHSAH. Be sure to subscribe and follow the entire Hospice Emergency Regulations series. At what point is it not an emergency anymore? That's another question I have.
Today.
June 22nd. June 22nd.
After the series is done.
Anyway, we'll continue to explore the issues that matter most to California hospice providers. For everyone at CAHSAH, and for Sharon and Cindy and Eric, I'm Mark Wilson. Thank you for listening, and we'll see you at the webinar and next time at the table. Take care, everybody.
Thank you.
Thank you, Mark.
Thanks, Mark.